Hi, good afternoon, everybody. Thanks for coming and taking time out of your afternoon to be with me. Today, we're going to talk about partial knee replacements, what they are, how they differ from full knee replacements, why you may or may not need one, and if you have any questions, just speak up during the talk, and I'll try and answer them. This is my disclosure page. I'm not getting paid by the manufacturer to give this talk, although if they want to pay me, I might consider it. Anyway, let's talk about what your knee looks like first. And the knee joint is composed of three bones: the femur, which is the end of your thigh bone, the tibia, which is the shin bone, and the patella, which is your kneecap. And there are several articulations in the knee joint. There are three compartments that articulate, that is, move together and glide over normally smooth, frictionless surfaces, which are the lateral condyle, the medial condyle, and the patella, which glide on the opposite smooth surfaces of the top of the shin bone and what we call the trochlea, which is the groove on the end of the thigh bone. And any or all of those surfaces can get damaged or arthritic, which is the breakdown of the cartilage on the end of your bone. And that may or may not lead to certain decisions about knee replacements. Arthritis is the breaking down of the cartilage on the end of your knee joint, and that is usually the most common form, a wear and tear condition that's degenerative. It is overwhelmingly increasing, and as baby boomers get older, there's going to be a huge amount of people with osteoarthritis, which is the wear and tear arthritis. It's a degenerative condition, and we don't really have a lot of ways to stop it at this point other than masking the pain. And we have lots of different ways of doing that, ultimately leading to just replacing that cartilage surface with an artificial knee. So this is what arthritis looks like. Exactly. So typically it's the wearing away of the smooth white stuff on the end of your bones, which looks like the white stuff that's on the end of chicken bones. We have the same thing. And it starts breaking down, and when it gets bad enough, you can see the underlying bone. And when those bones are exposed, it's very painful. And when we are treating arthritis, we think about treating ways to mask the pain, which are, we'll go over some non-operative ways to do that, and then we'll talk about surgical ways. Now, there are other reasons to get arthritis, and we call these secondary arthritides, and you can get that from diseases of the bone or systemic diseases like rheumatoid arthritis or lupus or gout or any of these other mechanisms that cause destruction of the cartilage from reasons other than wear and tear. And when somebody has arthritis, and typically it starts with the inner or medial portion of the knee, they tend to get bow-legged. And they come in looking like this, and they say, my knees hurt. And when you have progressive bow-leggedness, that means that you're wearing out the cartilage here, and your shin bone's actually kind of compensating this way. And you can see the space over here, which is normal cartilage, is gone over here, indicating that the normal cartilage is gone. Now, it can work the other way, where this compartment is worn out, and their leg goes the other way, and those people are knock-kneed, and that's more often seen in women, and that more often than not accompanies some other arthritic process, like an underlying inflammatory disease. Now, if you're in really bad shape, you can have arthritis of both compartments, and where in that case you would have narrowing of both of these articular spaces, and you don't get a deformity one way or another. But sometimes it gets so bad that the ligaments involved give way, and then you can end up having an unstable situation. Typically when you have arthritis, this is what you complain about. Your joints swell, they get stiff, and the typical presentation is somebody who says, I'm doing okay until I sit down. And then when I go to get up or go to get out of the car or get out of the movie seat, it hurts. And initially, we treat arthritis in a non-operative way using, activity modification, like making sure you don't have to climb a lot of stairs, or instead of running, telling you not to do high-impact exercises, use a cane or a walker, use some anti-inflammatories like aspirin or Motrin, or get an injection. And then lastly, we talk about surgery. And surgery is for people who have tried the non-operative regimens and they don't work. And I tell people that they ought to consider surgery when the pain from arthritis is getting in the way of what they want to do. So when it's really impacting the quality of your life and you've tried these other things, then you consider surgery. Surgery on knees, in particular, has been proven to increase your lifestyle and overwhelmingly be a way to decrease arthritis pain. 95% of people who have knee replacements or partial knee replacements have great results for the first 10 years. It diminishes a little bit after that, but even stays in the low 90s over 20 years. So we have data now that prove that you can have an excellent result for 20 years. Now there's some manufacturer now that says they even have a 30-year knee out there. And that is truly a marketing ploy because nobody has 30-year data on any knees. What that particular manufacturer did was cycle a knee joint in a laboratory for as many cycles as they thought would make up 30 years, and their knee still lasted, and so they say they have a 30-year knee. But no human being has ever had a 30-year knee, but we're probably getting to that stage as people start to live longer and they get joints at an earlier age. So here's a picture of a knee replacement, and this is most of a full knee replacement. The only thing you're not seeing is the plastic button that's on the underside of the kneecap that glides in the groove on this metal cap, which is on this end of your thigh bone. And then the top of the shin bone is also replaced with a metal plate, a plastic bumper in between. So that's a full knee replacement. So it's not the case that we just take a saw and hack your knee out and give you an artificial knee. It's really a resurfacing kind of procedure that leads to having smooth functioning joints again. Now, if you have arthritis confined to one place or another, and the most common is one side of your thigh bone and shin bone, you can have a partial knee replacement. And that is an operation where only one condyle, which is this curved knuckle on the end of your thigh bone, is resurfaced, a metal plate on the top of your shin bone, and a plastic bumper. In between, the nice part is you get to keep all of your ligaments, which you don't get to do with a full knee replacement, which makes you have a more natural motion, a more natural feeling in your knee. There's much less bony dissection. You preserve the parts of your knee joint that are normal, and you come away with a shorter rehab, a shorter hospital stay, and just as good longevity from these. Here's a model of one. You can pass it around. The only thing I ask is that you be careful because this particular implant has a mobile bearing that is stuck between the two metal surfaces and held in place by the tension of the ligaments around the knee, so it can pop out and fall on the floor, and then I won't have it to show the next group. But that's a partial knee replacement model. There's another kind of partial knee replacement called a patellofemoral arthroplasty, which means that the groove on the end of the thigh bone and the back part of the kneecap are replaced when you have arthritis. And here's a side view that's confined to that surface. And here's an end-on view of the kneecap where it glides on the end of your thigh bone and that breaks down. So if you have isolated medial compartment arthritis and the rest of your knee is normal, you can get one of those. If you have a lateral compartment arthritis and the rest of your knee is normal, you can get a non-mobile bearing version of those. And if your articulation between the kneecap and the end of your thigh bone is damaged, you can get what's called a patellofemoral arthroplasty, which is basically a metal plate on the end of your thigh bone and a plastic button on the very back of the kneecap here that glides in this groove. What you need to know is that to get a partial knee replacement, the rest of your knee, other than that damaged portion, needs to be normal. That means you need a normal anterior cruciate ligament, you need a normal medial collateral ligament. You cannot have a flexion contracture, which means a stiff knee. If any of these are abnormal, you're not really a candidate, as we found that partial knee replacements in that setting don't last very well. So if you have abnormal ligaments or a stiff knee or arthritis in other parts of your knee, you really should not consider a partial knee replacement, and that would push you toward a full knee replacement. And here's what an x-ray of a partial knee replacement looks like. You're seeing the model, but here I can show you where you saw that picture of the narrow joint space from the cartilage space being gone, where the two bones were touching. Now you have a metal cap on the end of your thigh bone, a metal plate on the top of the shin bone, and a plastic bumper in between. And these white lines are actually small metal wires in the plastic that let me know on x-ray that that plastic is still where I put it and not floating around somewhere else. That doesn't happen very often, about 1 in 400 chance that happens, but it's nice to see it on x-ray. Like I said, if you have a stiff knee or even a bad deformity like this, here's somebody who has an x-ray of their knee and has a 45-degree angulation of their knee, you're really not a candidate for a partial knee replacement. That is somebody that needs to be fixed with a full knee replacement and most likely needs some extra stability because of the deformity that is causing ligamentous instability. The nice part about partial knee replacements is it enables a fairly rapid recovery. Now, what you have to realize, and one of my professors once told me, it doesn't matter whether or not you're throwing a hand grenade in through the window or the door, you're still throwing a hand grenade in. So minimally invasive is minimally invasive for partial knee replacement as compared to a full knee replacement. But it's still fairly invasive when you talk about resurfacing the end of your bones and having an implant put into your knee, whether it's a partial knee replacement or not. And so what you need to know about that is that partial knee replacements relative to a full knee replacement end up in a much shorter hospital stay, and typically it's just an overnight stay. There's a much smaller surgical incision, which is typically about 4 or 5 inches long on the front of your knee, much less surgical dissection, and it really promotes a rapid recovery into full outpatient rehab within a few days, and within 2 weeks, people are walking without assistive devices and feel pretty good. It still takes about 4 weeks to get back to doing all the things you want to do, though. What you need to do before you have a knee replacement, and this is any knee replacement, is you have to have a thorough talk with your primary care physician. And this is not about the surgery, but you have the best outcomes when the rest of your medical conditions are optimized. So if you have heart problems or kidney problems or thyroid problems, you need to have those well controlled for a surgical procedure to be maximized. Also, if you're interested in partial knee replacements, you ought to see an orthopedic surgeon that does a lot of partial knee replacements, because like anything else, there's a bias toward how they perform based on how many you do and how well they're put in. And like any other joint replacement procedure, there's a few things that actually affect the surgical outcome later on. One is whether or not the implant has a record of longevity. And the one I use, which is called the Biomed Oxford implant, which was developed in Oxford, England, about 35 years ago, is really the longest lasting partial knee replacement in the literature these days. So we have great 20-year data on this knee. The other thing that influences whether or not your implant has a long life is how well it's put in by the surgeon, and that is influenced by the surgical volume. And so there are some numbers that people banter around, and what it turns out is that if you have a surgeon that does more than 100 joint replacements a year, those people tend to do well along with everybody who does more. And people who do less than 100 joint replacements a year tend to do less well. Now, having said that, that doesn't mean that a low-volume surgeon can't do good work. It's just that it's like anything else. When you bring your Toyota to a mechanic, the guy who's the Toyota mechanic seems to know the car a little bit better than the general mechanic. So keep that in mind. Surgical implant that has a long track record, and a surgeon that does high volume. And I think that's it. Quick and easy. What questions do you have? Yes?
What happens if we're saying partial knee replacement if the arthritis is in one particular area? When you do the knee replacement, does arthritis then attack some of the other parts?
Great question.
Can you repeat the question?
Good thing you mentioned that. So the question is, will arthritis affect other areas of the knee after you have a partial knee replacement? And the answer to that is possibly. Now, the reality is about 8% of people who have a partial knee replacement during some point in their life have that partial knee replacement revised. And that's because they do get some arthritis elsewhere that's symptomatic and not controllable with non-operative measures. 92%, however, don't. And of those people, most of them have arthritis that just stops once you cure the arthritis in one compartment. And so the idea and the literature suggests that if you do have arthritis in one compartment and you catch it in an early enough stage and you end up with a partial knee replacement, that there is a very high chance that you won't need anything else. Is it zero? No. If you have a full knee replacement to begin with, will you need another operation later on? Well, there's about a 10% chance over the life of that implant that you will require some other surgical procedure, because it's about half to 1% a year cumulative over time. So even with a full knee replacement, it doesn't mean you're going to get away without a surgical intervention later on. But that's a great question, because everybody wants to know, am I just going to have a second procedure? And if you have arthritis that is in other compartments, or even starting, you're really not a candidate for a partial knee replacement. So those people who get partial knee replacements are a very select group. There are people that really only have it isolated in one place, all their ligaments are normal, the other places are normal. Yes?
In my case, I injured my knee. I hyperflexed it. So as far as I know, I don't have arthritis. I don't have any symptoms in the other knee. But would a partial knee replacement be appropriate in that case as well?
Well, the question is, if I injure my knee, is a partial knee replacement appropriate? And the answer to that is, if the injury caused damage to the cartilage on the end of your bones, maybe. And that's called post-traumatic arthritis. It's a little bit different than the wear and tear arthritis that we get because we were born to the wrong parents or just bad luck. But it's not inflammatory arthritis, and that's really the key. You can't have a partial knee replacement if you have an underlying inflammatory disease, because like I said, partial knee replacements depend on the tensioning of the ligaments in the knee, and if you have an underlying inflammatory disease, not inflammation in your knee, but a systemic inflammatory disease, those ligaments can stretch out over time, and it'll make that partial knee replacement not last long enough. Yes?
What determines the need for a partial knee replacement? The level of pain or visibility on an X-ray or an MRI?
Okay, I have to repeat the question. And I'm going to repeat the question. The question is, what determines the need for a knee replacement? Is it the level of pain or radiographic findings? And the answer to that is probably both. And the reason I say that is that there's usually kind of a constellation of things. And certainly pain is the overwhelming reason to have any joint replacement surgery. And the question is it stemming from some process in your knee joint? And that's the answer that needs to be found. And the way you find that out is by doing tests and sometimes a diagnostic injection of some local anesthetic, just some numbing medicine in your knee. And if that takes away your pain, then we know that pain is coming from the knee joint. So if you have, it would be really unusual to have knee joint pain and a totally normal MRI.
Vice versa. When you have an MRI or an X-ray that shows a high level of arthritis, and the pain being tolerable, not fun, but tolerable.
So that question is the converse. Can you have abnormal findings on X-ray or MRI and tolerable pain? And the answer to that is I see that all the time. That is a much more common finding that I see people whose X-rays are horrific, and they say, I'm doing pretty well. And I think the reason they do pretty well is because when you have arthritis, most of the time it's kind of a gradually progressive disease, and you kind of get used to it. Most people I see who have arthritis have put up with some kind of pain for many years, and then something will happen, and they kind of spiral down. But it's almost always the case that they have X-ray findings that are not subtle. Yes?
I have 3 questions for you. So the first question I would like to know is, what is there a possibility of having one complete knee replacement and the other one possibly as a partial replacement?
Yes. The answer. Sure. The question was, sorry, I'm getting cues from the. Is it possible to have a total knee replacement on one side and a partial knee replacement on the other? And the answer is yes. If you are a candidate for a partial knee replacement and have had a total knee replacement, or if you have a partial knee replacement and the other knee is not a candidate for a partial knee. Yeah.
And the other two questions, what's the role of genetics and gender? Are men and women disproportionately more inclined to have these issues than men? And if parents have it, do children then also?
So the question is, what's the role of gender and genetics? And I have bad news for you. So that is that is about 70% of osteoarthritis is attributable to genetic predisposition. Now, on top of that, there is trauma, wear and tear, other things that I see that contribute to that. In other words, you could have parents that are very arthritic and you're getting along okay, or parents who are not arthritic and then you have some kind of previous knee injury that leads to a breakdown of the cartilage surface over time and you end up with arthritis. So there is a genetic predisposition, and it counts for a lot. The second part of the question was, is there a gender difference? And I don't think there is. There's differences in the pattern of the arthritis that I see based on men and women, but in terms of osteoarthritis, I think it's probably equal throughout the population. Any other questions? Yes.
This has nothing to do with the partial exactly, but what causes big fat knees when you don't have big fat knees normally?
When you're not fat, is that what you mean?
I mean, big.
Okay. So
Like a,
the question is, what causes big fat knees when you're not a
Yeah.
heavy person?
Yeah.
When your knees swell, that causes big fat knees. Your knees swell because the knees are coated with a lining of cells that produce joint fluid. And typically, we all have a little bit of joint fluid that lubricates our joint surfaces to make them rub smoothly on each other. When your knee joint gets irritated, that lining of cells does the one thing that it knows how to do, which is make joint fluid. It just makes more joint fluid. And that's what gives you a swollen knee. So I know if somebody comes into the office and they have a big fat knee, there's something going on in their knee joint, because your knee joints don't swell unless the lining gets irritated from something going on in your knee. And
this isn't high, but it's hard.
well, if it's hard, sometimes you can make bone spurs in addition to that big fat swelling that causes big fat knees. And that bone spur is your body's attempt to spread the load out over a bigger area. So when people say they have arthritic knees, a lot of times when the cartilage cushion wears down, the bones try and spread out to spread the load around, and that's bone spurs can cause you hard big fat knees.
Because I'm stuck.
Yes.
So you talked about,
I'm sorry. You're going to have to duke it out. No, I'm joking. In the back.
okay, you talked about it swells because something's going on inside the knee.
Right.
So your body's reacting to create a fluid to protect what's going on inside the knee. And then I'm told ice is your friend to get rid of the swelling. So if you reduce the swelling, you're reducing the protection of what's going on inside the knee.
Okay, so the question was, you're making fluid for protection, and now you're told to ice it so the fluid goes away, which is protective. And I think that is not a correct assumption, and that is your layer of synovium, which is the lining that makes the joint fluid, is stimulated, and making extra joint fluid not necessarily protective. It just makes extra ones because that's what it does. It's just stimulated. Those cells are stimulated and they make joint fluid. That's it. Just like your skin makes hair. You know, if you have more blood flow to your skin, you'll grow more hair. And it doesn't necessarily mean that that joint fluid is protecting anything. It's just a symptom of some underlying irritation in the joints. And when somebody says put ice on it because it'll get the swelling down, most of the time people, when their joint's very big and their knee's very swollen, that's uncomfortable. They can't bend it very well, and in extreme cases, they can't bend it at all. And if the ice isn't taking down the swelling just by cutting down on the amount of joint fluid that's being made, sometimes I have to put a big needle in there and suck it out, and those people feel better. Yes?
The bow-leggedness, does that go away with the knee replacement, or just the partial? Does that go
It will
away?
not go away. A partial knee replacement is not meant. I'm sorry, the question, I have to repeat the question. Will the bow-leggedness go away with a partial or full knee replacement? That's the question, and the answer is possibly. A partial knee replacement isn't made to realign your knee joint. So my stock answer to people who have partial knee replacements is that your bow-leggedness still might be there. But the reality is, once you spread that joint open a little bit, you get less bow-legged. For a full knee replacement, for sure you get less bow-legged, and that's because the bony cuts are based on tensioning all the ligaments in your knee, and they're only tensioned when you're out of bow-leggedness. So when you're bow-legged, in fact, does anybody have that model floating around? So when you're bow-legged, this ligament is now loose, right? So when I restore that to tension it properly, you won't be bow-legged anymore. That answer your question? Okay. But it's definitely not a cosmetic operation, unfortunately. Yes?
I'm told that my kneecap is in two pieces. Not something that I ever remember injuring, but is that a complication for a partial knee replacement?
No. There is an entity, and that's called repeating the question. So I have to repeat the question. The question is, my kneecap may be in two pieces. Is that a contraindication of getting a partial knee replacement? I will start over by answering. There is an entity called a bipartite patella, and that is when you are developing, the patella is in two pieces and typically fuses into one. And some people don't get a complete fusion, and they have a bipartite patella. And if you look at a picture of a patella, sometimes you'll see on an x-ray that they have a patella like this and a line going through it. Almost always it's kind of an oblique line about a quarter to a third of the patella up here in the superior pole, which is infused, and that's called a bipartite patella. And most of the time it's found incidentally. It's not symptomatic at all because it's held together with scar tissue and this band of ligaments that comes down. And so as long as the two pieces aren't moving, you don't feel like anything's wrong. So the answer, that's a long answer, to say no, it's not a contraindication. Unless you have arthritis under that kneecap, then yeah. Yes? How many partial and full knee replacements do I do a year? Well, I have to qualify that being the new guy in town, so I'm still building up here. But I can tell you in my old practice, I did about 250 joint replacements a year. Of that, probably about 50 were partial knee replacements, about 100 to 150 knee replacements. And in terms of partial knee replacements, I do a relatively high volume because Number one, I see a lot of people with knee arthritis just because I've done a lot of knee replacements. And number two, I do believe that if you catch arthritis early in its stages where it's only affecting one side, that can be cured with a partial knee replacement with a much better result, with just as long a track record as a total knee replacement. So it's seriously not for everybody, but if you're a good candidate, if you were my sister, I would say have it done by somebody who does a lot of partial knee replacements.
Is age a factor? They seem to tell me, wait until you're really in terrible pain.
Is age a factor? Well, there's difference between age and pain. So age is a factor in that we typically like to push people along without having a knee replacement because you're burning bridges. As soon as you have one done, it starts to wear out. It's like buying a car. And certainly the older you are, the longer they last, because they last based on how active you are. And if you're young, like Bo Jackson, he had his hip replacement, didn't last 4 years. He was a professional football player. He was young, had a hip dislocation, and ended up with arthritis in his hip. And those are scenarios you don't want to get into. Having said that, I try and have people balance the quality of their life, And when it starts getting in the way of what you want to do, I'm not typically looking at 25 or 30-year-old people. I'm looking at people at the young end, probably late 40s. And you have to have a serious conversation with yourself and with your doctors and see if it's right for you, knowing that there is a finite lifespan for this. And when people are at a point where they have end-stage arthritis, they've tried all the non-operative regimens, and they're still having a decrease in the quality of their life, I try and have an honest conversation with them about whether or not they should do it. So, is age an issue? Kind of. Now, is pain an issue? Definitely. If pain's getting in the way of what you want to do, in the olden days, which wasn't too long ago, 30 years ago, we said, take some aspirin, here's a cane, go sit on the porch. That's not acceptable anymore. And people want to be active, and this is the way to stay active. Yes?
You mentioned that 2 weeks recovery and a month for full recovery. If you have like a full-time job, in a month you'd be back on your feet all day?
It depends what you do. If you're a bricklayer, probably not. If you sit at a desk, sure.
No desk.
What's that?
No desk. On your feet, cement floors.
Yeah. So what I typically do at 4 weeks for people who are up and active at work all day is I have them go back to work kind of part-time for a few weeks to see how things go.
After a month?
Well, it depends. It really depends on them. But certainly at a month, you should be working toward getting back to work. And whenever that is, if it's 2 weeks or 4 weeks, when you're ready saying, okay, I'm ready to try going back, it's a trial of usually 4-hour days. And then people call me up and say, okay, I'm ready to go back.
Are you talking in that case about full or partial?
Either one. I didn't repeat the question, and I'll have to live with that. I'm sorry. Yes?
I understand this is your second lecture. What was the first one about?
If you missed the first one, there's a makeup test. And the first one was about non-operative treatment for arthritis and what you can do shy of surgery.
These only.
That will be on the website, I hear. For knees only,
Other question?
knees and hips, weight-bearing joints.
What's the website, is that?
It's the Parkview website, it's Parkview AMC.
The question was, what was the website?
Talented and funny, huh? Where do you
Say
find that?
AMC?
Yes, AMC.
Well, thank you everybody for coming, and I guess stay tuned. I'm hearing there's going to be 50 more lectures.
Yes, we're going to have more lectures. I think this is it for April. We're going to
Excellent.
start back up in